Hello again. So Henry here, the Appendix Whisperer. So any of you that follow me on social media know that I am the Appendix Whisperer. Now that is a title that I've been bestowed. I bestowed it upon myself. Okay. I rigged the contest and I won. So here we're going to go into the appendix. So optimizing the appendix, and there's the Appendix Whisperer right there. LOL. And here's a nice picture of the appendix with the iliac artery right there. Beautiful. This is with the Logic E10. Fantastic machine. All right, so vermiform appendix. Vermiform is Latin for worm-like. Obviously, it looks like a worm. So the appendix comes off of the cecum, which is this right here. And you can see this structure right here. This is a tinea coli. If you saw the gastrointestinal lecture, you know that that's this band of tissue that follows the entire colon. And the appendix usually comes off of that. The appendix is blind ending, should be compressible. It can be filled with fluid, can be filled with air. Air is actually a good sign that there's no inflammation, especially when it's inside the lumen. Or fecal matter. When it's a lot of fecal matter, that can be a little confusing because the appendix can be over 6 millimeters. And it might, someone who's inexperienced might say, oh, that's an appendicitis. But if there's no other inflammatory markers, it is not appendicitis. Here's a clip showing the appendix, and there it's compressed. It's cutting it off, but it's about 3 millimeters there. So it receives its blood supply from the appendicular artery. Now, when there's inflammation, you're going to see all this hyperemic. All right, and the appendix can vary in length from 2 to 20 centimeters. I think there's a world record for the largest one. I do not remember. I think it was 50 centimeters or something. Don't quote me on that, but I honestly think it's in the Guinness Book of World Records. All right. So here's a clip of the normal appendix. Here you can see the tip. You can see a gut signature. For those who saw the gastrointestinal lecture, the gut signature is 5 layers. And the middle layer is the submucosa. So here you got subcutaneous fat, muscle, and the appendix. And right behind it, you have the right iliac artery. So this is again with the Logic E10 with the 24 megahertz transducer. This is obviously a very slender patient. You're not going to get this image on an adult or a bigger patient. Here's another clip showing the appendix compressing. So the appendix should be compressible unless it's filled with fecal matter. And if that fecal matter does stay in the appendix for a long time, even if there is no inflammation, it can turn into a fecalith, which is kind of like a calcified ball, I guess, of feces, which can lead to inflammation, but not always. So here's the appendix. You see the lumen is filled with fluid, and that's it compressing. This is the psoas muscle here. So as you press down, you can compress it. Obviously, again, a slender patient. Here you got your external, internal, and external oblique, internal oblique, and transversus abdominis, so the obliques. Okay, here is another diagram. Again, tinea coli, appendix, appendicular artery, terminal ileum, cecum, and ascending colon. So here's a cecum, appendix, and this is mesenteric fat. When there's inflammation, all this is very red. The blood vessels are very engorged, very bright, very red. The fat gets also swollen. The vessels on the fat also get very red. And on ultrasound, the fat's going to be echogenic, which they call from CT. Fat stranding, that's a term that's originally from CT because you see the inflammation of the fat looks like strands. On ultrasound, I use the term fat stranding too, even though you don't see strands, you just see echogenic fat. You could also use fat edema because that's what it is. It's like a lymphedema or edema of the fat of the mesenteric fat. So that term, you can use it interchangeably. This is the peritoneal wall. So when there's inflammation of all this, you get inflammation of the peritoneal wall again, which is peritonitis. Okay, McBurney's point is the clinical location of the appendix, or where the appendix should be. And quite frankly, it's 2/3 the way from the anterior superior iliac spine to the umbilicus. And even if the appendix is more laterally or more medial, like draped over the vertebrae, if it's inflamed, your pain is going to be focused right there because that's where where the nerve fibers run. I had an appendicitis. My appendix was very lateral, and my pain was right there at McBurney's point. So that's where you start to scan, but you're always going to have to go in all directions to find the appendix, whether it's normal or not. The variability of the appendix is very variable. So the retrocecal portion is the most common one. You're going to hear that a lot when people can't find the appendix. Oh, it must be retrocecal. Cecum is full of gas or whatever. So keep that in mind. It could be around the ilium. It could be deep in the pelvic. It can be draped over the vertebrae. There's lots of variability. It could be up by the kidneys, by the kidney and liver, especially in smaller patients. So here's a Frank Netter diagram. Again, McBurney's point. This is where the appendix should be. And then all the variability of location. Oftentimes the appendix is coiled or serpiginous like a little snake. It could be deep in the pelvis. This is a hernia. You can have a normal appendix in the hernia. That's a MAN hernia. And then people with situs inversus, you can have the appendix on the left side, very rare. And then much higher in the abdomen, especially in little kids, because their abdomens are smaller, so there's a lot less space for the appendix to be. All right, here's a clip of me scanning the appendix with the GE V-Scan, a little portable scanner that connects to your cell phone or other digital device. And that's my dog, Taco. Okay, a lot of comments I get from the internet is like, oh, Henry, you always find the appendix because you're in pediatrics. You have small patients. They're very thin. And yes, majority of patients are small, but obesity is very common in pediatrics as well. So can you find an appendix in adults? Yes. Can you find an appendix on obese patients? Yes. Obviously, it's harder. Your success rate is going to decline, but you can. And here's a clip showing just that. All right, landmarks for the appendix. First and foremost, I always go down to the psoas muscle and the iliac artery and vein. Oftentimes, the appendix is draped over the iliac artery, quite frequently. If it's not there, I'll go lateral to where the obliques are. A lot of times it's there in the paracolic gutter. If it's not there, I'll go up and down the ascending colon. Little kids, you're going to find it in the right upper quadrant quite frequently. I'll go down into the pelvis if the bladder's full. Sometimes it's there. Not frequently, but every now and again, as you saw in the other slide, about 9% of the time. And sometimes it's crossing midline, especially in very small pediatric patients. The appendix could be draped over the vertebrae. Okay, so here's using the psoas as a marker. Here you got your appendix looped on itself. So this is a tip here, and this is the appendix, and you can see it coming off of the cecum here. And then here's the psoas muscle, lower pole of the right kidney, and then the appendix. Now, remember, you're not always going to get the appendix perfectly longitudinal like that. Sometimes it's serpiginous, sometimes it's looped. So in that case, if you get the appendix, regardless of whether you're sagittal or transverse in the body, you'll get like several little circles of appendix. And it's going to be hard to get the appendix in a longitudinal view. In that case, you can do clips to show the entire appendix in longitudinal and transverse. Okay, here's using the iliacs. So right iliac artery, right iliac vein. Here you see the appendix in longitudinal or sagittal. That's the tip of the appendix there, and that's there in transverse. So here you would take the transducer, add some pressure to try to compress as much as possible, and it's typically 3 to 4 millimeters. Here's a clip showing the appendix. So here's your ilium. So terminal ilium, which will then go into the cecum. Here's your psoas muscle back here. Your right common iliac artery, and then posterolateral, your right common iliac vein. Quite frequently, it's usually draped over the iliac artery, which you'll see right there. That's the beginning of the appendix, and then whoop, right over the artery, and then dipping down there. So that's where you find it a lot of times, if it's not retrocecal, of course. All right, here's another video of an appendix variation. Quick reminder that the appendix could be anywhere in the right lower quadrant, sometimes even in the right upper quadrant. So here you have the common iliac artery, and here's your appendix. And oftentimes the appendix will drape over the common iliac artery. Now, something to keep in mind is that the ureter also passes this plane and can be confused. So keep that in mind, especially if there's urothelial thickening, which is edema and thickening of the epithelial lining of the ureter. That won't end. It'll keep on going down into the bladder. So it won't be blind ending. And it won't have gut signature. So you won't see all the mucosal layers of the bowel, which is the appendix. So this appendix starts to dip down 4 millimeters. So it's normal. You can see it starts to dip down further here. You got your psoas muscle here. Further down, psoas muscle again. And here is pretty deep there. And here is your external iliac artery and internal iliac artery. This appendix is tucked very neatly in between that bifurcation of the common iliac artery. So you got your aorta, common iliac artery, external iliac artery, and internal iliac artery. And here's your appendix there, just chilling. So always keep that in mind. It could be anywhere. Yep, he's right. All right, so here's one posterior to the bladder. So here's your bladder. Here's your bladder. Bladder, you see it right there behind the bladder. Kind of lateral to the bladder here, this portion at least, but it does dip to be behind the bladder, a normal appendix. I have had cases of this where it's appendicitis, and it's behind the bladder. Okay, here is a 7-year-old female. You see right upper quadrant and transverse. You see this little appendix right here, and then tucked right between the right lobe of the liver and the right kidney is the appendix. And right there, here's another case. Same thing. The tip of the appendix is right by the lower pole of the right kidney. Here's another one. Let me see if I can remove myself. Well, no, I can't. But here you can see the appendix, kidney, liver. And the same thing right here. Right kidney and appendix. Little piece of the liver. And here we have another clip, I think. Let's watch. Quick reminder that the appendix could be anywhere. No, that's the one we just saw. Never mind that. Quick. All right, so positioning. Obviously, we usually start in supine. Supine is the most common way we're going to find the appendix. I like to use both right lateral and left lateral decubitus. I'll do left lateral decubitus first. However, when you do left lateral decubitus, air and gas rise, so it might rise to the right side of the abdomen, obscuring the appendix more. In that case, right lateral decubitus might work better. Now, when you're scanning right lateral decubitus, it's going to be a little weird because now you got to go and scan the right part of the body, which is on the bed, and you might have to angle your arm a little weird, so that's not good for ergonomics, but you can hold the transducer like this, right? Let's see if I have something that can represent transducer. Here, a limb brush. You can hold the transducer like this and then try to scan like that. It's still going to feel a little weird, but at least you're not going to be externally or internally rotated in your shoulder, and you might have a good time, easier time finding that. And then prone. This almost never works. I've maybe found 2 appendix this way, and the appendix has to be high. Since the appendix is not always high in the abdomen, you might not see it, but I have found it twice. That's just a last-ditch effort. I do like to find the appendix. I don't give up very easily. And just recently, I've been using Trendelenburg. So when the patient's supine, you lift the foot of the bed up, and the gas shall rise, and the bowel shall move towards the liver, and might reveal the appendix. It's been very successful. Ever since I implemented this in my department, everyone's been using it, and it definitely helps. So Trendelenburg, if you have that option in your bed, just make sure to tell the patient, I'm going to put your head down. Don't worry, you're not going to fall, hopefully. And then you can find the appendix. It's helped a lot, even for cases of acute appendicitis, which would have been missed otherwise. So very, very, very helpful. So here's a case where I'm scanning supine. You got the right common iliac artery. The right common iliac vein is a little compressed. I couldn't see anything. I put the patient in Trendelenburg, and then boom, the appendix showed itself. It's 3 millimeters. It's normal. So it's very, very, very useful, very helpful. I did post this in my stories or on a reel on Instagram, and people have been using it, and a lot of people have been sending me messages. Oh my God, thank you. It works. So try that. All right, so acute appendicitis. So acute appendicitis, the appendix is usually non-compressible. Remember, fecal filled appendix is going to be non-compressible. If there's no other inflammatory signs like hyperemia, fat stranding, free fluid, it's not appendicitis, all right? And we'll go over that later. So the appendix has to be greater than 6 millimeter, again, with other inflammatory findings. If the appendix is just greater than 6 millimeters and there's nothing else, there's no pain, there's no hyperemia, there's nothing, it's not appendicitis. So don't just use 6 millimeters, greater than 6 millimeters as your go-to. There's other things. The appendiceal wall can be thickened. It can also not be thickened. This is a case of appendicitis here, and the appendiceal wall is not thickened. Can have an appendicolith. Now, you're not going to see an appendicolith a lot of times. You're going to see it frequently, but not a lot of times. In adults, appendicitis is usually caused by an appendicolith. I had appendicitis. I didn't have an appendicolith. So it's a more common cause in adults. Children, they can have appendicoliths, but not all of them. And they're usually, the cause is usually other, for appendicitis is another thing like a bacterial infection or something. There's going to be hyperemia, so increased blood flow of the appendix, of the fat around the appendix, and then fat stranding or fat edema, echogenic fat. So you might not have all those things, but if you have a few of those, it's appendicitis. If you have all of them, even great. And free fluid. You can have free fluid with a normal appendix, so don't use that as a gauge for whether there's appendicitis or not. Even if the patient's in pain. If the patient's in pain and you're scanning, we do so many appendix ultrasounds, and a lot of people complain of pain and their appendix is normal. So could be that I press hard because I do, or they're very sensitive, or they're sick with something else. Maybe they have some type of viral infection and their skin is sensitive. Who knows? But you need to have several of these findings in order for it to be acute appendicitis. All right, so this case is pretty interesting. Let's go over it. So here is a picture of the right upper quadrant, right? Here's a patient we got sent, young patient, for UTI and right flank pain. So I'm going to give you guys a second to look at this image and see if you see anything. So you can see the right lobe of the liver, the tip of the liver here. You can see the right kidney and sagittal. Right kidney looks pretty good, but there's just a little structure right here. Stood out to me. Patient was in a little bit of pain, not a ton of pain. So that's the appendix. This patient had appendicitis. So this is with the curved probe. So obviously the resolution is not going to be very high. After I went and took images of the linear probe to really show it. Oh, and I didn't go over probes. So just like the gastrointestinal, for your right upper quadrant images, you can go with the curved probe or a sector probe, whatever you would use for a regular abdomen. And then right lower quadrant, you want to use your linear because the linear is going to give you that high resolution you want. Very skinny patients, go as high as you can, 15 megahertz, or like that example I showed earlier, 24 megahertz. So this is with the curved probe, but you can see there's, little target lesion there, echogenic fat. This is the lower pole of the right kidney right here. And this is with the linear. So you got the tip of the liver, kidney, echogenic fat, and an edematous hyperemic appendix. So this patient had appendicitis. Now, I would have done the kidney ultrasound. It would have been fine. They would have sent home the patient with maybe clindamycin or some other antibiotic for a UTI. That would have calmed down the appendix, but then they would have showed up maybe a week later after they finished the antibiotics, and the appendicitis might recur. Because you can't treat appendicitis with antibiotics, but there is a chance for it to recur. When you remove the appendix, obviously the chance of it recurring is extremely low. You can get stump appendicitis, but that is quite frankly very rare. But you'll still get sometimes orders for that, at least in my history. And here's it in transverse. So I don't remember it was like, I think 7 millimeters, hyperemic, fast stranding. So acute appendicitis. All right, here we have a 14-year-old female. Sorry, these are two different cases. So here we have a 9-year-old male. So we have a pretty big appendix, no appendiceal wall thickening, but the appendix itself was 1.5 centimeters, pretty big. You can see there's fecal material fluid on appendicolith. So fecalith, you see a stone right here with shadowing and not much hyperemia, but this is a case of appendicitis with a fecalith or appendicolith. Now this one is a 14-year-old female, also has an appendicolith. So here you have the psoas muscle, right common iliac artery, right common iliac vein, the appendix, appendicolith, hyperemia, and look at the appendix right here. There's definitely wall thickening. So the appendiceal wall should be less than 2 millimeters. I didn't mention that. I'm mentioning it now. Less than 2 millimeters or less. So if it's 3 millimeters or more, that's appendiceal wall thickening. But you can just look at it qualitatively. Usually the appendix wall is pretty thin. So appendiceal wall thickening with some debris or material in there, and it's 1.1 centimeter. And then you have fat stranding, so echogenic fat. Here's a case of a patient that was bigger, and we could see the appendix with the linear. So here's the appendix. The appendix is pretty long, fat stranding. You can't really make out the walls that good. There's definitely appendiceal wall thickening. The appendix was 2 centimeters, pretty big. So I used the curved as well. Here you can actually see the appendix coming off the cecum and then dipping down. So this is a case of appendicitis. So use all the probes you can. If the linear is not working, use the curved. And honestly, with the new GEs, and I'm sure I'm not sponsored by GE or anything, but they are a friend. But other machines, I'm pretty sure as well, even with the curve, they can go up very high in megahertz in frequency and get really, really nice high resolution images. Here's another clip. So remember I told you appendix in loop. Here's another clip. Iliac artery, iliac vein. And here's the appendix doing a little loop-de-loop. Whoop. And that's the tip of the appendix right there. You see appendix looks very stiff. It's there's some fat stranding. The fat is echogenic. This was a case of appendicitis. But it was pretty deep under the iliac artery and iliac vein. So remember, lots of variability. Here's a transvaginal image for the order of pelvic ultrasound, but patient had appendicitis. So here's the appendix here. You see there's fat stranding. This is the right ovary. I mean, I know it's the quality is not there. You got to kind of like squint your eyes a little bit, but it is the ovary. And yeah, that was an appendicitis on transvaginal scan. So obviously this appendix was pretty much deeper in the pelvis. Here's another case. This patient did have appendicitis, so you can see the appendix right here. But the appendix was, giving a little hug to a right ovarian follicle. Now this one, I think it was less than 3 millimeters, so quite frankly, when you do a pelvic ultrasound and they have an ovarian follicle like that, our radiologists don't even mention it because it's physiological, it's normal. And if you say they have an ovarian cyst, they're just going to keep on coming for follow-ups. And so they had a little follicle, they're about to menstruate most likely. But of course, the appendix was literally on it. So I had to mention that appendix right close to an ovarian follicle. And, they had to call the surgical team to prepare the patient for a laparoscopic appendectomy, but not before they ordered a pelvic ultrasound to evaluate that cyst. So very annoying. Okay, here's another clip of an appendix with a fecalith. I like to call it appendicolith because it just sounds cooler. So here's the bladder. You can see it's right next to the bladder. Right there. And then it dips down this way. You have the appendicolith right here with shadowing. There's wall thickening and fat stranding. So the echogenic fat, the appendix, and the fecalith. And is this the same clip? It may be. I think this is the same appendicitis, but you can see there's a little bit of free fluid there. Appendiceal wall thickening, echogenic fat. Oh, here you can see you can actually see the appendicular artery and all those little branches feeding the appendix. Iliac artery, iliac vein, common iliac. So it's hyperemia. So you see the appendix here, and this is a tip. The quality degrades a little bit when you add it to the PowerPoint, but this was actually very, very nice clip. Here's another. So fat stranding, very big appendix, super thick. And then whoop, there's something here. So fat stranding, psoas muscle, iliacs, thick-walled appendix, more fat stranding. So this was a patient that had a perforated appendicitis. Now let me pause that. When there's perforated appendicitis, especially if there's already like an abscess formation, they'll usually give the patient antibiotics, do a treatment with that, then schedule the appendectomy later on when all the inflammation and everything's down. Because if there's an abscess, the abscesses can get, they can grow, they can have larger abscesses, they can collect in the pelvis. So they want to make sure they control that before they do a surgery. So this is after antibiotic therapy. You can still see there's still an abscess there. And this is the appendix here. So after antibiotics, you scan this, you put color Doppler, it won't have a lot of hyperemia because some of the inflammation has calmed down. Sometimes if the abscess is big enough, they can do the surgery, so they'll do antibiotic therapy and then put drains. And in our hospital, we do, if the right lower quadrant has an abscess, they'll do a drain there. If there's any abscess or fluid collecting posterior to the bladder or in the cul-de-sac, they'll do a transrectal drain. All right, so then that is a case of perforated appendicitis. Now, ultrasound is good at finding perforated appendicitis, but it can miss, some, especially if it's subtle or if it just starts. Some of the things you can notice are loss of gut signature. It could be focal or it could be pretty much global around the entire appendix. You can have free fluid. Now, again, you can have free fluid for many, many things: ruptured ovarian cyst, other problems with heart failure or renal failure, or many, many causes. Abscess formation. If there's an appendicolith and the appendix ruptures completely, that can become free floating. We've had a case of that where there was perforation of the appendix and an abscess, and within the abscess you can see the echogenic appendicolith. You're still going to have hyperemia and fat stranding or fat edema. So this patient, the appendix was very large. I don't remember the size. I think it was close to 2 centimeters. You had an appendicolith. The appendix is so big it almost looks like a gallbladder with a gallstone and sludge. But it was an appendix. So you see the proximal appendix here, and then here's dilated. There's a tiny bit of free fluid here. Again, psoas muscle. Tiny bit of free fluid there. A lot of hyperemia. This was an early perforation, but it's hard to tell with ultrasound. Sometimes it's not as subtle, and those are much easier to call. So here you got an appendix, fat stranding. The appendix is dilated, and you got like almost loss. Not almost. You have loss of the gut signature here. There's some layering here, and then you got free fluid within the echogenic fat. Here's with the 15 megahertz probe, free fluid here. You can make out the gut signature as well. So this was a case of maybe there was perforation, and surgically there was. So if there's a case like that where subtle, they will take them to surgery, and once they do the laparoscopy, they'll know if there's perforation or not. And the appendix was 1.8 centimeters, pretty big. Now, no matter what, they always start the patient on antibiotic therapy when there's an appendicitis. This was a 5-year-old female. Okay, this case is interesting because this patient had 10 prior appendix ultrasounds over the years. Every time they order an ultrasound, I look at the history and they had 10 prior ultrasounds. I was like, come on, man. They really want this kid to have appendicitis. They're not going to have appendicitis. Of course, when I scanned them, there was appendicitis. So immediately you see it's free fluid here, very echogenic fat. Appendix dips down, huge appendicolith. Okay, wall thickening. This is the iliac artery, iliac vein, psoas, free fluid. So this was a case of perforated appendicitis. Since it was perforation and a large appendicolith, they treated with antibiotics, and the patient had some abscess drainages. And 2 months later, they came back to see if they can have the appendix removed because the appendicolith was still there. And there was still some inflammatory changes in the area, just not as much. So you see the proximal appendix, the wall thickening is low, but there's still free fluid and this huge appendicolith or fecalith. Here's a case where you can see the appendix in transverse. You can see the fat stranding, and you can see right here. Here's the thickening of the appendix wall, the lumen, and here is a defect within that wall that is a perforation. So there's a mural defect which led to perforation. Here's that same case. So that case happened to be a 7-year-old male with emesis, vomiting, and right lower quadrant pain. So you see a tiny bit of free fluid here, pretty big appendicolith. And actually there was more free fluid. So I think I did say likely perforation, and they still went to surgery and it was perforated. This appendix was huge though. Here's another one, much clearer example of losing the mural gut signature. And then you can see the outline of the appendix here, and then all of a sudden it looks like it continues here, but then there's this little bleb of fluid here. So that's probably where the perforation start. Very echogenic, fast stranding. The appendix is 1.6 centimeter, huge. And then there's a free fluid area right here. You see the free fluid is complex. So this is already an abscess that's forming. So that's muscle. This is a bit of the cecum, an abscess. This is bladder. So this is a panoramic from lateral to medial. You see there's free fluid. This is the tip of the liver right here. Again, the obliques, external, internal, and transversus abdominis. Fat stranding, very echogenic fat. Definite wall thickening, and here's the bladder. So the fat stranding is even abutting the bladder wall. And there also was an appendicolith and very echogenic complex fluid. So this patient had drainages put in and treated with antibiotics. Okay, here's a case of a right upper quadrant appendicitis. So you have your liver, kidney, and the appendix is tucked right there between the two. And there is hyperemia, wall, and dilated appendix at 1 centimeter, tiny bit of free fluid, and fast stranding. So always look up in the right upper quadrant. In fact, that's the protocol. I don't think I went over that. For the protocol, we begin in the right upper quadrant, take sagittal and transverse images, include the gallbladder, because obviously gallbladder stones is a common cause of abdominal pain. Not in children though, but you still see it. Show the liver and right kidney interface, make sure there's no free fluid in the Morrison's pouch, and then work your way down the colon, take pictures of the right lower quadrant. I go from right upper quadrant immediately to bladder, and then I can focus on my attention on finding the appendix. So the bladder, sagittal transverse images, make sure there's no fluid posterior to the bladder or any collections, and then you can go to your right lower quadrant, start at the iliac artery and vein, and do your magic there. This is a 4-year-old female, by the way. Here's another case. So this is why we begin in the right upper quadrant. So immediately you see, okay, there's this Morrison pouch collection. So you know you're headed for something, right? Some type of collection, some type of abscess formation. Here's a panoramic showing the collection in the right lower quadrant. You see there's some little debris in it. Not a lot, but here is the same collection there around the bowel. You see some linear echoes as debris. And then that collection there. This was a perforated appendicitis on an 11-year-old male. Sometimes you might not even see the appendix. It might be so perforated that you can't find any appendiceal tissue, but you can see fast stranding. And obviously there has to be differential diagnoses for this. You say, okay, either perforated appendicitis, or maybe they have a very bad colitis with abscess formation. Maybe they have bowel perforation with abscess formation. Maybe they have a very bad case of Crohn's disease with abscess or collections. So those are differentials, but you usually go from common to less common. And common appendicitis is very common. Okay, here's another one. I don't know if this is a clip. It's not. But this was, so here's the appendix. See, because I put appendix there. So there's fat stranding, the appendix wall thickening, the appendix is dilated. I don't even have to measure that. I know it's appendicitis. Fat stranding. Here's a little bit of the colon here. Subcutaneous fat, muscle. And so here's cecum, appendix, iliac artery, iliac vein, and then this complex fluid collection, which is an abscess. And you see the abscess is right above the bladder. So they had to have a drain put in to treat this abscess. This is a panoramic view. Now, this has happened before, especially just not that long ago. One of my students had this happen. They saw this and they're like, oh, it's a normal appendix scene. Because you see this, and then in transverse, it looks, it's circular, just like the appendix. Because sometimes you might go transverse on the ileum, and if it's compressed enough, it can look a lot like the appendix, but you'll see peristalsing. Now this, you can also see peristalsing on this, but only a little bit. So this is the ureter, right? So here's a bit of the psoas muscle. This is the ureter, follows the same plane as the appendix. Here you can see small bowel. There is some wall thickening of the ureter. So this patient had actually a UTI with urothelial thickening. So if you see this, I don't have any transverse images of this, but the transverse is like that. It's like a little target lesion. Be aware. Follow this. Remember, the appendix is blind ending. This is not blind ending. You can follow this all the way down to the bladder. If you lose it because, here's your iliac. If you lose it because there's bowel in the area, try to follow it up into the kidney. Look at the kidney. Check the pelvis of the kidney, because when there's urothelial thickening, especially this much, it's going to go all the way up the ureter. You have UTI starts in the bladder, urethra, then it starts to ascend. The inflammation starts to go to the ureters, then to the pelvis of the kidneys, and then you can get also pyelonephritis. So be aware of this pitfall. And here's an example. So here you got your kidney and transverse. Even though this is the left kidney, same thing for the right. You're gonna have urothelial thickening. So this is the pelvis, and this is urothelial thickening. Quite frankly, what do I keep saying? Quite frankly, quite frequently, this is seen in UTIs. And these are other potential pitfalls. Gassy. If the patient is extremely gassy, you might not be able to find the appendix. You can use pressure or transducer pressure, compression. Reverse trend elevator can help here. Right lateral decubitus can help here. But sometimes no matter what you do, there's just too much gas. A non-compliant patient, when you work in pediatrics, that's pretty much almost all the patients. But, you can still do it. An appendix that's greater than 6 millimeters, but no other inflammatory findings. So you have a fecal-filled appendix. It's large. It can even be a centimeter. The ERCs are like, oh, this is appendicitis. The appendix is huge. No. If there's no other inflammatory signs, there is no appendicitis. Terminal ileitis and other inflammatory conditions. Now, you can have lymphoid hyperplasia of the appendix, which is a great mimicker of appendicitis. We've had a few cases recently. So you have an appendix. It's about 6 to 7 millimeters. There is a little bit of hyperemia. The fat around it is a little ergogenic. They go to surgery, and it's actually not acute appendicitis. It's just lymphoid hyperplasia, but that's a pathological finding. You can only see it in histology. So naturally, with the appendix, the old saying goes, when in doubt, cut it out, especially a long time ago when there was no imaging. If you had right lower quadrant pain, quite frequently you'd get your appendix removed, even if it was normal. Obviously, it's not the case today, but still, we still have some appendixes that are equivocal, and it's just better to take them out than to question it, and then it is appendicitis, and then it ends up perforating, because then you got a big problem in your hand, peritonitis, abscess formation, and the morbidity and mortality does increase with in those cases of perforation, and the recovery time is very long, as opposed to acute appendicitis. You have your surgery, you're out of the hospital within 2 hours after the surgery, and you have a little bit of pain for a couple of days, but it's almost nothing. An adnexal cyst, erroneously targeted as a cause of pain. Sometimes you can have, tubal ovarian abscesses, and it can be very tubular and very thick walled and with debris and hyperemia, kind of the ring of fire. The ring of fire is any tubular structure that's inflamed that has vascularity to it is going to look like a ring of fire. Not every ring of fire is an ectopic pregnancy. So that can be another case of that. Okay, here we have a case of appendix that's 1 centimeter. It's 1 centimeter. The tip of it. Sorry, I had to stop because my dog was coughing up a storm. So here's an appendix. It's 1 centimeter. Huge, right? ER sees this quantitative data, and they're like, wow, this patient has appendicitis. It's up there by the right kidney. But look, there's no hyperemia. There's no fat stranding anywhere. Everything looks normal. The proximal appendix is tiny. It's 3 millimeters, which is normal. And then all of a sudden you have this bloop. Appendix. There's no wall thickening. This is fecal matter within the appendix. This on its own is not appendicitis. Now, maybe a longer time ago, this case would have gone to surgery. They would have removed it. But right now, as this one looks, they will not take this to surgery. What could happen here is in the future, this more denser part of the feces can calcify and become an appendicolith. That by itself does not require surgery, because I've had patients with a normal appendix and an appendicolith that was seen on x-ray and they didn't have appendicitis. So can this turn into appendicitis in the future? There's always a possibility, but at this point here, there is no appendicitis. Also, clinical, this is a 13-year-old female with left lower quadrant pain. You can't see it, but it's down here. So her pain's on the left and her appendix is normal. They still order appendicitis because my hospital, we're doing a ridiculous amount of appendicitis. We do like 20 to 30 appendixes a day. And a lot of them are normal, but we do get a lot of positive ones. The most I've had in one day is 5. So this is a case of normal appendicitis. That's why you got to look for other inflammatory findings, hyperemia, clinical findings like right lower quadrant pain, rebound tenderness, things like that. Laboratory data like leukocytosis, elevated white blood cells. Here's another case. Same thing. Here you got your 13-year-old male, common iliac artery, common iliac vein, beautifully, clearly seen appendix. You can see the vertebrae right here. No hyperemia. There's no wall thickening. The appendix is 7 millimeters, but it's filled with feces. Now, this feces can sometimes be a little dense and you can't compress it. So the proximal appendix, again, normal. There's nothing in it, nothing in the lumen. Then a little bit of feces is collected at the tip, mid to tip. No other findings. There's no inflammation, no hyperemia, no pain. A lot of these patients, you scan them and they're not even in pain. Normal appendix. Now, okay, here's a case of, I remember early on in my career, I've been doing ultrasound almost 20 years. And when I first started learning the appendix, I had a hard time with it, like everybody else does. And I had a couple cases where I had the terminal ileum and I thought it was the appendix. So this, for the untrained eye and in a still image, in real time, you'll see peristalsis. But to the untrained eye, you see this, oh wow, this is big. You measure this is probably like a centimeter. And there's hyperemia. There's wall thickening. This is appendicitis. But here you can see it doesn't follow. Usually the appendices are much more smoother. You kind of see these little waves here. Iliac artery, iliac vein. So it's in the right spot. But this is a terminal ileum. This patient had terminal ileitis. And then you have a normal appendix, which measures 5 millimeters. Now you could overmeasure that and include the serosal surface. And it will be 6 or more. And with a little bit of free fluid. But it's not appendicitis. They had right lower quadrant pain because they had terminal ileitis. All right. So Burkitt's lymphoma. Now, Burkitt's lymphoma is a B-cell non-Hodgkin lymphoma, right? There's 3 types. The endemic variant, which is common in areas of malaria infections and Epstein-Barr virus infections. And this one commonly infects the jaw. And these tumors can get really, really big. But also distal ileum, cecum, ovaries, kidneys, and breast. Now, the sporadic type, which is a type you're probably likely to encounter here, it's non-Hodgkin. It happens to 30 to 50% of in childhood. And the ileocecal region is the most common location. And then there's another type that's associated with immunodeficiency syndromes. So here we have this patient was, I don't have the age, but they came in. So this one is a 14-year-old male. They came in with right lower quadrant pain. They ordered appendix, and I saw the appendix pretty quickly, and it looked big, it looked dilated, no wall thickening, maybe some fast stranding, but it was a big appendix. But then as you follow the appendix, there was this structure here, which that looked odd. It looked like almost a mass, but then when you put color Doppler, it is a mass. There's internal flow, and here's the mass measuring about 7.6 centimeters. So they did CT with contrast, and this patient ended up having a Burkitt's lymphoma. Now, they did very well. So they got chemotherapy and they did very well. I scanned them a long time later and they were in remission, doing well. Here's another one. 17-year-old male. Came in with abdominal pain in the right lower quadrant. So naturally they order an appendix ultrasound. We see the appendix. Pretty much the entire thing here. The tip should be here. It's normal. It looks normal. But as you go try to follow the appendix into the cecum, you start to see this. There's some wall thickening of the cecum. And then you see this. Now, this looks like a mural lesion at the level of the cecum. So all this is cecum here. So all this is colon. You can see the submucosal here, the echogenic layer. And there's just this. And now you can say, wow, maybe there's a base appendicitis. So the rest of the appendix is normal and there's inflammation of the base. That's not common. Usually the tip can be swollen and the rest of the appendix is normal. So this was another lesion. Here you can see it again. It looks like a mural lesion. It was also a Burkitt's lymphoma. All right, this is an interesting case. No appendicitis. You see the appendix here. The tip's about right here. You see the gut signature. But inside the appendix, you see all this little stuff here and there. So that's a case of ascariasis. So it's pretty much a worm infestation in the appendix. You're not going to see this commonly here. You can also see some in the intestines as well. And you can also see these in the gallbladder. I have a few cases shared with me that of gallbladder ascariasis. So you're not going to see this with any frequency in the United States, but in other countries, this is a quite common problem to have intestinal worms. So I thought that was a pretty cool case to share. I shared this one on the GI lecture, but in case you didn't catch that one, or even if you did, I'm going to share it again here because it's quite interesting. So here we have a 5-month-old male with intermittent abdominal pain. These patients are usually going to order a intussusception ultrasound, and the patient did have an intussusception. So here you got the liver, and here you got the intussusception. So that's an ileocolic intussusception. The ileum is going into the colon, the cecum and ascending colon. There's a lot of hyperemia in the area. This can happen too with intussusceptions. There's a little bit of free fluid. Here's the right kidney. But this patient had a twofer. So here's the right kidney, liver, and then they have appendicitis with a little bit of free fluid. So they had ileocolic intussusception and appendicitis. So naturally, when there's ileocolic intussusception, they'll take the patient to radiology and do an air enema to reduce it. Since this patient had a surgical case as well, they went to surgery, had the intussusception reduced surgically, and then the appendix removed. Pretty rare. So that's pretty much for the appendix. You can follow me on any of these social media platforms: Facebook, Twitter, YouTube, TikTok, and Instagram. I don't know why I don't have Instagram here, but Instagram is pretty much where I'm most active when it comes to like messaging and replying to comments. The other ones, not so much. I do post quite frequently on Twitter, but I don't really go on there that much. I have a lot of appendix cases. I'm always sharing appendix stuff because we do have a lot of appendix cases. So ultrasound is cost effective, portable. Usually the ER patients come to us, so that's no problem. It's non-ionizing radiation. And it's once you learn it, once you get used to finding the appendix, the normal appendix, it becomes quite easier. There is a longer learning curve. So when you learn to scan the gallbladder, the learning curve for that is much shorter than scanning for the appendix. But if you follow these little tips and tricks and follow me on social media, I'm always posting and re-upping my data and my techniques for appendicitis. You can become very good at finding the appendix, even in adults. All right. So thank you very much. And I think I will be available later for some Q&A so you guys can ask me stuff. Again, thank you very much for having me in this conference. It's been my pleasure and I'm honored. Bye.